Elliot, welcome to the podcast. It's really nice to be able to connect, having known your work for a while now.
Thanks for having me on, Alex. It's great to be here.
Yeah, so we're going to be talking about sort of thiamine and gut health today, which I think, as you mentioned off air, is kind of it's a topic that isn't particularly well known, but perhaps needs to be much more well known than it currently is. So I'm looking forward to sort of dipping into your brain and your experience with this. But before we do so, are you happy just to perhaps introduce yourself a little bit for people that aren't yet familiar with you?
Yeah, of course. My name's Elliot Overton. I run a YouTube channel called EON Nutrition. I'm trained as a nutritional therapist. Like yourself, I did some further training in the whole functional medicine thing. I went to America, trained at A4M, and yeah, I've been practicing for 5-6 years now. I over the years, I've kind of, I guess you could say, I've unintentionally specialized in the topic that we're going to talk about today, which is the medicinal use of thiamine, of vitamin B1. But I have a much broader interest, you might say, in the concept of orthomolecularism. So that would be using or looking for underlying imbalances in vitamin and mineral cofactor metabolism and how that contributes to chronic health issues. And so the principles are that if you are to identify the underlying imbalance or identify what's high and what's low, then if you can try to restore some normality there, if you can rebalance things using these building blocks of the human body, then things tend to improve in and of themselves. And fortunately, from a clinical perspective, that does seem to be the case. But yeah, that's my focus. Most people probably know me mostly for the concept of looking at vitamin B1 specifically, though.
Hmm. You mentioned you sort of unintentionally got into this area. Is there
Yeah.
any is there any kind of story behind that? How did you kind of unintentionally get to where you are?
Yeah, so I was taking down a bit of a rabbit hole. I was doing some research. I'm a bit of a bookworm, so I came across the work of a medical doctor. His name's Dr. Derek Lonsdale. He's actually this year he just turned 99, and he's still publishing scientific papers. If you check out his work on Google Scholar, so he has been prolific. For about 60 years, he was working at the Cleveland Clinic as a pediatrician, and his work really focused on trying to highlight the underlying or the prevalence and severity of vitamin B1 deficiency, how it is quite difficult to identify via testing and all of the different kind of conditions that might respond to it. So as he was a pediatrician, he did specialize, I believe, in autonomic nervous system problems, or another word for that is dysautonomia. But he treated thousands of patients using this vitamin specifically. And when I came across his work, I guess a light bulb went off because it made sense, but it's something that I'd never been taught in nutrition school. You know, you learn the basic biochemistry, what vitamins, minerals do, etc. And a lot of the focus, even in the alternative health field, because, you know, from much longer time before I even started studying nutrition, I was interested in concepts like methylation and, you know, how different vitamins can be useful for different health conditions. You learn a lot about vitamin B12, folate, you know, methylation, B6, even niacin. There's been a lot of research, a lot of public awareness, let's say, on the potential benefit of using something like niacin for cardiovascular diseases. And so there is a general awareness, at least in the alternative health field, of the concept of using vitamins or isolated vitamins in super physiologic doses. So doses that you can't get from food, but doses that you would get in a supplement at a higher dose, and that having a positive effect. But when I came across Lonsdale's work, he was talking about vitamin B1, and it was like, wow, okay, this is really interesting because I don't know this, but you know, I've never come across this information, and I was kind of led to believe, and especially when you're studying nutrition textbooks and things like that, there is this underlying assumption both in the conventional medical system and also the alternative medical system that that vitamin B1 deficiency was mostly eradicated with food fortification. And that it's not very common, and that the symptoms will generally present as these classic, let's say, deficiency diseases. So this is your very severe Wernicke encephalopathy, beriberi, these kind of things. And yeah, there basically wasn't that much awareness of it. So I began studying his work. I got hold of everything I possibly could. And then I also his book, Thiamine Deficiency Disease, Dysautonomia, and High Calorie Malnutrition, which he co-authored with Chandler Mars. Excellent book, by the way. Anyway, so I was devouring all of this material. And during the time I was seeing clients, and certain people would start presenting with symptoms which I felt might be applicable. They were similar to what he was describing. So I started using it. I figured, right, okay, well, there's no guide, there's no recommendations. I'll just start using this vitamin and see what happens. So I started people on it. I started people on a low dose and then the higher dose, and then kept on building up and building up. And what I saw was nothing short of miraculous. Not only was it completely surprising that I'd had people get in contact with me with these pretty severe health conditions, and they tried a bunch of other things, and yet B1 was the missing link for them. And that was like a real shock for me. And this was years ago. This was a real shock because I never anticipated that magnitude of benefit. But the most interesting thing, and this relates to what we're going to talk about today, is I started seeing that people's chronic digestive issues would disappear. And it's like, I didn't anticipate that. I wasn't looking for that. I was looking for it maybe to improve some body pain or improve dizziness or improve, what I considered to be nervous system problems. I never expected that someone's SIBO would miraculously get better within like a couple of days. I never expected that I'd see people with low stomach acid or, poor bile output start noticing a functional digestive system once again within a very short period of time. So I saw this, and this isn't something that is classically considered to be responsive to B1. It's not really even something that Lonsdale spoke about a lot. So I wasn't looking for this, and yet it kind of happened by chance that I saw that all of these people saw benefits, and that's really what led me down the rabbit hole. And it kind of got to the point where I was basically reading as many scientific papers as possible. Most of them published, they're not even published in English. They were never transferred, and we can go through why this is, but basically most of the research, specifically on the different forms, is actually published in Japanese or Chinese. So I'd have to spend hours and hours and hours, paying for these, signing up to these Chinese medical journals, paying for the studies, and then putting them through DeepL. Obviously, I don't speak Chinese or Japanese, so I'd put them through DeepL and actually try to make sense of it. And obviously, there's a choppy translation, but you can get the general gist of it. And what I learned was that back in the day, particularly throughout the 1960s up to maybe the 1990s, the Japanese and the Chinese were using thiamine in really high doses for just a variety of different problems, including gut issues. But unfortunately, this was never filtered through into Western thought. And so I saw that, and I figured out people need to know this, and I need to kind of drill this down as much as possible. And one of the criticisms that people, on my channel or whatever will have is that I tend to hyper focus on B1, and I unashamedly do, because I feel as though until there's more awareness of this, then I will continue drilling down as much as possible to try to filter this information into more of a public awareness. Yeah. I hope that makes sense.
Yeah, total sense. And we need people to be doing that drilling down and hyper focused, and then we can integrate it into our broader knowledge ultimately. So thank you for doing what you're doing. One thing I want to touch on that I've heard you explain on your YouTube channel before we dive into kind of the gut connection, is this idea that we're not just talking about like a basic deficiency. And we're talking about actually re-stimulating or stimulating enzymatic processes that might not be working optimally. So are you happy just to touch on this concept before we move on?
Yeah, very briefly, because it is a broad concept. There are two different types, let's say. From what I've seen, there's two different types of people who respond to vitamin B1. The way that we are generally taught, and is more of a conventional concept, is that nutritional deficiencies occur because of a dietary lack. So they mainly occur in people who don't eat enough. that, like, as in they don't eat the right foods which contain those vitamins. And as you know, the RDA, or the recommended amount, is for many of the B vitamins. If you look at, for instance, vitamin B1, it's only 1 milligram to 1.5 milligrams. Now, it's really not that difficult to achieve that through the diet, but the general consensus, or the theory, is that if the only people who are going to be susceptible to a deficiency are the people who are not eating enough, or are, for whatever reason, consuming something which is known to deplete B1. So, for instance, alcoholics, in certain cases of gastric bypass surgery. There's other niche kind of instances where conventional doctors might suspect B1 deficiency. But I think the way in which the conventional kind of view looks at nutritional deficiency needs to radically shift, because it would seem as though there are a variety of different things which change the demand which someone has for different nutrients. And one of those, particularly B1, let's just say if someone is dealing with some kind of a chronic health issue, there's good reason to assume that their requirement for nutrients goes up across the board. And there is a lot of evidence to substantiate this. But there's also a concept which is really not touched on, but there is also a body of evidence for, is that what can happen at the cellular level sometimes is that there are certain processes which become blocked or inhibited or inactivated. And what ends up happening is that produces a situation which is basically equivalent to a deficiency. The thing is that the problem, or the original issue which is causing a blockage on metabolism, it's not related to a nutritional deficiency. It's not related to the diet. So I'll give you an example. Is you've got one type of person who might be consuming a lot of alcohol. They might have the very traditional risk factors for B1 deficiency. They might have chronic gut issues, and they might just be on a very restricted diet because they're doing some SIBO protocol or something like that, and they are genuinely low. So for those people, they might just need to have an extra few milligrams every single day for a couple of weeks, and you would see that their symptoms will respond very quickly. On the other hand, we have people with quite severe neurological or neurodegenerative conditions, and this would kind of include people with, say, fibromyalgia, people with Parkinson's disease, people with multiple sclerosis, these supposedly incurable conditions. Well, these people don't necessarily have a nutritional deficiency, but they are people who many times, say 7 or 8 times out of 10, are responsive to very high doses of B1. And the reason for this is because if you look at the literature, it would seem as though the disease process itself can cause a let's say basically block or inactivate B1 dependent enzymes, so thiamine dependent enzymes inside the cell. And even eating a diet which is rich in B1 is not going to influence that in any way. The only way in which you could potentially resolve that situation is by using high doses. So you have a group of people who basically have like a functional deficiency at the cell level, which is completely unrelated to diet. And this is not going to show up on any tests, any functional tests. Regardless, you can have a localized or focal deficiencies in just one region of the brain. For instance, if you look at the evidence on Parkinson's disease, they've shown that within just the substantia nigra, which is the area which becomes dysfunctional in Parkinson's, there is this localized B1 deficiency because of this blockage on enzymes. And ultimately, there's nothing you're going to do from a nutritional standpoint that's going to address that, because simply giving a small amount every single day is not going to fix it. In fact, what you need to do is you apply a different concept, and this comes back to the concept of megadosing, which is it's related to how they treat disorders of metabolism. I'm not sure if your listeners are familiar with that, but basically you have people with, say, hereditary or genetic defects in their transport systems, or in basically the proteins which allow their cells to absorb vitamins. And so for those people, the only way in which they, an example would be genetic hyperhomocystinuria, for instance. So these people generate massive amounts of homocysteine, and the enzyme which requires vitamin B6, it's got a very low affinity for dietary B6, and so the amount that they get through the diet is just not enough. This enzyme becomes blocked up, and you end up with massive amounts of homocysteine coming out in the urine. the way that they treat this from a conventional medical standpoint is by giving mega doses of vitamin B6. And the concept is that when you give mega doses, you saturate the cells and you can kickstart those enzymes to start working again. And it's a similar concept with thiamine, in that if people who have these diseases where the enzymes which use thiamine are blocked, then the only way to restore function to those enzymes is to give mega doses and saturate the body. And sometimes that is indefinite. But again, so coming back to the principle, I hope I haven't spoken for too long on this, and then it makes sense. Basically, you have some people who it seems as though their condition is due to a genuine deficiency or insufficiency. And we'll go through the difference there. But ultimately, you have another group of people which they don't have a dietary deficiency. Many times they're doing all of the things right. They're already taking a multivitamin. They're doing all the stuff with the diet. They're doing all the stuff with detoxification, everything like that. You do everything with these people. No, there is a cellular, like a biochemical defect, let's say, that is only going to be responsive to super high doses for consistent periods of time. So apples and oranges, oftentimes they're confused. And I try to make a distinction between these two concepts, because what is going to work for someone who is just mildly insufficient is not necessarily going to work for someone with a very severe condition. And this applies the people under the severe category, probably run-of-the-mill people who do not have like diagnosable medical conditions, but do have, like I said, fibromyalgia. They do have ME/CFS. They do have even chronic inflammatory response syndrome to some extent. So these are going to be people that a lot of practitioners will be seeing. They're not going to respond to lower doses of B1 like the deficient population would. Different population.
Sure. Okay. No, that's really helpful. I think obviously a key point for us to understand within this, especially this fact that labs, bloods, testing might come back completely normal. It's not going to rule out this scenario ultimately. So now we understand a bit more around, I guess, the mechanism. How best would you like to sort of bring in the concept of B1 in this context and the gut, whether we're talking SIBO, IBS? I know you've commented on GERD on your YouTube channel as well here.
Yeah. Okay. So, well, I mean, if your listeners are members of the general public, then we could just very quickly go through what is a B1 deficiency, or where do you get B1, and kind of how does that usually look, and why is it often missed? For practitioners, they will have learned this in nutrition school, but they probably are not applying it clinically because not many people know about this. So just a very brief recap. Vitamin B1 is one of the B-class vitamins, right? It's found, it's ubiquitous throughout plants, throughout animal foods. It's really not that difficult. If you're consuming a diet which is focused on whole foods, it's not going to be that difficult to obtain the recommended amount, which is 1 to 1.5 milligrams. Now, if you were taught in medical school or nutrition school or whatever, it was well known. It was basically the first vitamin which was identified, and this was in Japan. It was early 20th century, but it'd been known for a very long time prior to that. Basically, the Japanese, you had this class division where you had the higher classes, the lower classes, and the higher classes, as part of a status symbol back then, what they used to do was they used to polish their rice. What that means is you remove the brown part of the rice. This is fundamentally the difference between white rice and brown rice. And it was only the higher classes who could afford to have their rice polished. And what they started identifying was that during this process, or after this process of polishing, the people who would consume a lot of the polished rice started developing very strange symptoms. And these would typically be classed, nowadays they're classed as beriberi. And this is either going to mainly affect the brain and the peripheral nervous system, or it's going to affect the heart. So in the heart, it can cause acute heart failure. It can cause edema. It can cause problems with maintaining blood pressure. Although that's less common, the more common form is based in the brain, and it's based in the peripheral nerves. So these people would have very strange neuropathy. They'd lose sensation. They'd lose the ability to properly coordinate their motor reflexes. They would develop very severe cases. They would develop confusion, what's called ataxia. They'd lose their balance. They would actually lose control of their eyes. And so their eyes would start, it's called nystagmus, but basically when your eye muscles lose the the ability to basically control where your eyes are going, which direction it is in. So it really causes a neurological disaster for people who have this deficiency. And so they identified this very early on. And that's why later on, most of the research was done in Japan. What they discovered was when they isolated it, they started giving the patients who had these symptoms isolated vitamin B1. They discovered that it effectively cured all of the symptoms. And so that's when they started fortifying the rice with this B vitamin. Now, from a conventional medical standpoint, it's considered that those deficiency diseases, so beriberi, Wernicke encephalopathy, they're mostly common in people who are alcoholic, who have digestive surgery, like I said, very severe digestive inflammation and disorders of malabsorption, let's say, and some other niche kind of health conditions. But that's considered to be, those are the diagnostic criteria. So you have certain symptoms, which if you match, they'll diagnose you as a B1 deficiency. Or if they measure your blood, serum thiamine, then they'll diagnose you as having a deficiency. They'll put you on a low dose. But other than those diseases, it's considered that this is very rare, right? It's very rare. But why is this relevant in the modern world? Well, if we think of what we've done in the West, particularly since the 70s and 80s, our consumption of what Lonsdale would call high-calorie malnutrition, which is a concept that you and probably most of your listeners are familiar with, is we started refining these foods, the foods that we're eating. We take everything out, we destroy everything, and then we try to replace it with synthetic vitamins to account for the losses. But then again, there's a lot of food that we consume that isn't actually fortified if you're consuming junk food. So there's this concept that similar to what was happening in Japan, is that the people who were consuming white rice, they would develop this deficiency. Well, it's very similar in a way to consuming junk food, which has had the thiamine removed from it. And the reason why this is very basic terms, is that thiamine is absolutely central to energy metabolism, and particularly, or let's say most importantly, is central to glucose metabolism. Now, there is a direct proportional relationship between the amount of glucose or carbohydrate that you consume and the amount of thiamine that you need. And if you look at the biochemistry layout, you can see why. It's really quite simple, is that there is a pathway called glycolysis going into pyruvate and then entering into the TCA cycle. Well, that pathway, the enzyme which does that, requires thiamine, high amounts of thiamine. Whereas if you compare it to, say, protein metabolism or fat metabolism, you do not require that pathway. And so the early research and research since then has shown that people who consume high amounts of carbohydrates, their demand for B1 goes up. On the other hand, if you have someone who's on a lower carbohydrate or ketogenic diet, their demand is almost halved. And it's interesting. So basically, thiamine helps you make energy from glucose. And if you don't have enough thiamine, you can't make energy from glucose. It's very simple. Something else to consider is that the enzymes which use thiamine are also what are called rate limiting. And there's some kind of a very interesting kind of philosophical, let's say, part of this, where some researchers have looked at B1 dependent enzymes and have said that they are quite unique compared with other enzymes involved in metabolism. These ones that require B1 is very interesting, actually, in that they're rate limiting, meaning that when they slow down, every single thing, every other process slows down alongside it. So for instance, if you want to make energy and you have enough of the B vitamins, enough B2, enough, B3, B9, whatever, biotin, but you don't have enough B1, it doesn't matter. It means that the rate at which your mitochondria are generating ATP or energy is going to slow down anyway. Okay. So, I think that's a very basic overview. One of the reasons why you would see changes in the neurological system, the peripheral system, the brain, is because aside from being this really important cofactor for how we make energy, it's also pretty central in how nerves communicate with one another. So how we are passing messages from the brain to the rest of the body using nerve signals. And thiamine is not only important for the production of some of the neurotransmitters, but it's also needed for the neuron to actually release neurotransmitters at the synapse. So there's this kind of non-energy related role, which is a direct function of thiamine. And therefore, if you don't have enough thiamine, then, and this comes back to the gut, I think this is a good entry point, because if you do not have enough B1 for whatever reason, or let's say the body cannot use this vitamin for whatever reason, then the messages conveyed from the brain cannot get to the rest of the body in the correct way. And if we ultimately come back to the gut, this is where it gets very interesting. And this is kind of the rabbit hole I was led down, because I mean, you've done the IFM program, you've done a lot of the functional medicine stuff. You studied, you got your personalized nutrition at CNELM, I think. So basically, you're familiar with the trends, let's say, in alternative medicine and alternative health. And when I studied every book that I've ever read, there is this, let's say, this hyper focus or strong emphasis on, if you have gut problems. Of course, we know now that the gut issues are related to multiple different diseases. For instance, if you've got intestinal permeability, if you've got gut infections, these kinds of things, this can be a segue into developing much more dangerous, or let's say long-lasting health conditions later on. So gut is really central to health. Everyone knows that. But there is this hyper focus on trying to address gut issues from the bottom up. And what I mean by that is, there is this tendency in alternative medicine, and I've succumbed to it myself, is that if you see a patient with gut problems, you immediately think to look in the gut. For instance, if someone presents to you with bloating or symptoms of low stomach acid, you would think, okay, they have low stomach acid. Therefore, what I'm going to do is I'm going to prescribe hydrochloric acid, right? Or I'm going to get them to do some other thing which is known to increase stomach acid. Really, that's a band-aid. That's a symptom management. It's not getting to the root cause. You might test them for gut infections, but they might not have H. pylori. They might do. You know, you're going to be investigating, and I know you as a clinician, you will do this, and this isn't a bad thing. This oftentimes it can work wonders. It's fantastic. It's way better than the conventional approach, but at the same time, it misses, I think, many cases of people whose issues do not originate in the gut, in that the gut problems, and I think this is the crux of the matter, and I'll end here just for the moment, but ultimately there are a portion of the patients that practitioners see, and the people who I personally saw whose gut problems, they appear to present in the gut, as in all of the manifestations of the person's problems are within the enterical digestive nervous system, but that was never the cause. That is merely a symptom of an underlying systemic problem. And just by focusing on gut, so gut responsive therapies, for instance, probiotics, dealing with gut infections, L-glutamine, fixing leaky gut, you know all the protocols, right? For those people, there's a lot of people who might get mild symptom benefit, but it does not fix their problem. And the reason for that is because that is not the root cause of the problem. The root cause of the problem is actually a higher level mechanism, most often based in the brain, based in the peripheral, connecting to the autonomic nervous system in the gut. And the issue is they are not getting the correct signals from the brain through the vagus nerve to tell the digestive organs what to do. And so the digestive system as a whole simply is just responding to what it's getting from the brain, which is mixed signals. So I think that that is one of the things that is super common and is really missed by a lot of people.
Yeah, I think that's such a key point, Elliot, around the bottom-up versus top-down approach. And there are other examples of this, I guess, when we think of gut-focused hypnotherapy and the success rate that can have, which would be another kind of top-down approach. But
right,
I've said for a while now, you can't have a healthy microbiome in an unhealthy host. The microbiome it's completely interconnected with what's going on sort of holistically and systemically. And I think you've done a great job of starting to show us how B1 can have this sort of huge cascade of consequences into so many different parts of the digestive system. So I guess from what you said there, are you happy to move on to maybe talking about B1's connection to stomach acid, to pancreas enzyme production? I've heard you talk about it from a bile perspective. So all of these what are referred to in the research as sort of endogenous defense mechanisms against SIBO
Hmm.
are seem to be somewhat dependent on what you've been talking about with B1 here.
Yeah, indeed. Okay, so as I originally said before, I started seeing patients with who would respond their digestive condition, which they may not have even come to me for. Their digestive issues had resolved for some unknown reason, and I was not anticipating this. Now, Lonsdale mentioned this briefly. However, there was really nothing published on this in the literature. Now, there is a condition. I said before, you have this concept of an end stage deficiency disease. It is known, although it's considered to be extremely rare, which I disagree with, is that you have this end stage deficiency of thiamine, which causes beriberi. Now, there is a subset of beriberi, or let's say a class of beriberi, which can manifest only in the gut. This is where it gets interesting. In some patients who have a very severe B1 deficiency, they don't get the classical triad of symptoms in the brain. They don't have the classic peripheral neuropathy. They do only present with symptoms in the gut. And this is called gastrointestinal beriberi. Now, again, is very severe. So this would be a complete shutdown or paralysis of the GI tract as a whole. These people would be extremely constipated. They would have nausea. They would have vomiting. They would have malabsorption. And most of the time, they would be admitted to the ER department because they're so ill. Now, again, that's the only thing in the West that really would suggest that there is a connection between B1 and digestive dysfunction. However, if we go to very basic anatomy and physiology, we look at how the digestive organs actually work. So there is this concept of the digestive system working, let's say, somewhat independently from the rest of the body. And that does seem to be the case. There is this like migrating motor complex. There's a lot of functions that occur in the gut, which may be microbiome mediated, which are, let's say, isolated to the digestive system as a whole. So it does seem to work. Even when you cut away the vagus nerve, there is some functions of the digestion which work autonomously from the rest of the body. But that's it's not really a useful way of looking at it. If we just go to basic anatomy and physiology, then we look at how digestion actually works, like what goes on. Like you said, the first lines of defense. Well, the body has employed various mechanisms to prevent the acquisition, let's say, of pathogenic microbes. So one of the first things that we do is we make stomach acid. In the stomach, we release hydrogen ions, and we're essentially rendering a very acidic environment to prevent the overgrowth of certain bugs, right? That's one form of defense. Likewise, we have a sphincter. We have two sphincters. We have propulsion. So if you look at the stomach working as it does in real time, not only it is very coordinated set of events, which is amazing that it all happens and you don't even have to think about it. It's non-conscious, which is important. We'll get to that in a minute. But ultimately, you have this coordinated set of events where you have one sphincter opening, one sphincter closing, etc. You have this propulsion, your movement. You've got this highly acidic environment. You've got pepsin release, etc. Until you make this kind of very thick, mushy paste that is then goes into the small intestine. So you have the function of the stomach as a whole. If you look what actually tells the stomach to do that, it is the enteric nervous system. Okay, it's the nervous system. So there are messages which are sent from the brain through a nerve, which I'm sure many of your listeners are familiar with, called the vagus nerve. And this is let's say, a function of the parasympathetic branch of the autonomic nervous system. So the stomach, knowing how to do that at what times, knowing how much stomach acid to make, knowing how much to propel food when it needs to, knowing when to open and close the sphincter, is coming from the brain. It's coming from the brain through the vagus nerve. Okay. Same thing in the intestine. So the release of bicarbonate of enzymes from the pancreas, the propulsion of food through the small intestine, the development of immune cells at the intestinal barrier. In fact, even the intestinal barrier itself is dependent on messages coming from the brain to the vagus nerve. okay, through the vagus nerve. And the vagus nerve is basically connecting. It's like a tendrils all throughout the enteric nervous system. And the nerve bundles are so dense. Some of the densest nerve fibers are in the human gut. And there's this concept that, you've got 80% of information potentially going up from the gut to the brain rather than from the brain to the gut. But honestly, I think that the amount coming from the brain to the gut has been understated, or the importance has been understated. And for this reason. So something that I'd really like your listeners to appreciate is that every single function of digestion, bar some of the autonomous things like the migrating motor complex, every single function of the digestive organs, and this includes the release of bile from the gallbladder, this includes the propulsion of food right the way throughout the intestine, every single one of these things is dependent on messages traveling through nerves from the brain, through the vagus nerve to the gut. Okay. And here's the thing is that if there is anything which blocks or prevents those messages from being sent, then the digestive organs lose the ability to know what to do. So you've got two main functions of digestive organs, right? You've got secretion and you've got motility or propulsion. Now, both of these functions begin to decline when, again, for whatever reason, there is an impairment of information coming from the brain to the gut. Okay. So this is what I consider the top-down approach, right? And this is where things like, meditation and all of this other stuff, which is a lot of these things are looking at improving vagus nerve function. So you have people who have high vagal tone or low vagal tone. And if you look at a lot of the evidence on inflammatory conditions, on IBS, there's a lot of digestive research, or let's say research looking at gastroenterology, which is specifically focused on improving vagus nerve function, and it shows positive outcomes. And you're probably familiar with a lot of that stuff. Vagal nerve stimulation, for instance, vagus nerve stimulation can radically improve inflammatory bowel disease. It can radically improve IBS and SIBO. There's a lot of people who know this. There's a lot of research that's been done on it. So that is very interesting. This is a factual piece of information that the vagus nerve is central to maintaining digestive function. So I'll give you an example. You have a patient come into you and they say that they get chronic bloating, they're constipated, they've got low stomach acid. What's the first thing that you're going to be looking at? Usually what we're taught in functional medicine or nutrition, alternative nutrition, whatever you want to call it, we're taught, okay, do a gut test, do a stool sample, look for an infection, look for this, look for that, look for that. Prescribe betaine hydrochloric acid, give digestive enzymes. If they come up on their test, they might have low pancreatic function, or low pancreatic elastase, so you prescribe digestive enzymes. You also see that they've got high zonulin, so you see they've got intestinal permeability. So the first thing you think to do, I'm going to try sodium butyrate, I'm going to try L-glutamine, I'm going to do all of the, by the book, alternative things that you do to fix leaky gut. And again, that is a useful concept for symptom management. But what we're not taught to look for is, okay, maybe, just maybe, it's not a coincidence that someone's stomach is not releasing enough stomach acid. It's not a coincidence that is co-occurring with their intestine also not propelling food at the right rate, or their pancreas also not releasing enough digestive enzymes. I mean, again, there's a lot of coincidence theory, let's say. It's usually, if you see a patient like this, most of the functions of their digestive system have basically shut down. They require laxatives. And it's we don't ask the question. We automatically assume that it's because of the microbiome, that it's because of the gut bugs. Whereas we're not necessarily, I think, trained to look at, okay, is what we're looking at let's say a collection of symptoms which highlights, okay, the main central issue here is that none of the digestive organs are getting the right inputs from the nervous system. This is a higher level problem that we should be, considering, I think. And again, I don't want to kind of project too much, because that was just the way that I was trained to look at it. So I know that there's many practitioners who are branching out, and there's a lot of interesting research looking at this stuff. But for the most part, I was very disenchanted, or let's say I wasn't happy with the results that I was getting with patients, where oftentimes they would go through multiple different practitioners. They would be put on, maybe they'd be put on antibiotics from the doctor. Then they might be put on like 6 months of herbs. Then they might be put on like a gastrointestinal restoration program or something like that. And oftentimes these people are like nomads. They go from one practitioner to another practitioner because actually no one can help them. And they come to me and they're like, well, look, I tried this for the gut. I've done this, I've done that, and did that, blah, 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 blah. And so I say to them, I'm like, okay, well, maybe the problem is not in your gut. And they're kind of like flabbergasted by that. But ultimately, this person is presenting with a collection of symptoms, which I think, at least in Lonsdale would have put it, and I've seen this play out in real life, what we're looking at is a form of autonomic nervous system dysfunction, okay? Is that we're looking at a faulty communication from the brain to the gut, and nothing that you do in the gut is necessarily going to fix that because it's not getting to the root of the problem. And like you said before the call, no one is going to have a positive, like a healthy microbiome if the gut is perpetually, like if the actual intestinal tissue itself is perpetually dysfunctional for whatever reason. So there is that. So just going back to what we said, and again, I don't want to go on for too long here, but ultimately, I began seeing by chance that people would respond pretty miraculously within, like sometimes within 24 hours to this treatment of thiamine, which I never anticipated. So what I did was I started digging into the literature, and it turns out that it was one of the first ever studies looking at induced thiamine deficiency in man. I don't think it would be ethical to do right now, but this was published in the 1940s. And what they did was they took six patients, they put them intentionally, they put them on a diet which was like 1/10 of the amount of thiamine that you need. So it was like 10 micrograms or something per day. And they followed them up. They kept them in a controlled condition. It was within like a hospital setting for, they put them in there for 3 months. And what they found was that what they were looking for at that time, they'd heard from the Far East, from in Japan, oh, there's beriberi, there's all of these symptoms that are going to occur. So they're looking for that and seeing how long it took for these people to develop those symptoms. They were flabbergasted. By the end of the study, no one developed those symptoms. No one developed beriberi. No one developed Wernicke encephalopathy, which they were anticipating. So they actually made the wrong conclusion. They said, oh, well, B1 can't cause this problem because these patients didn't get it. No, what they got instead, and this is where it gets very interesting, is they developed a collection of symptoms very early on that you would never associate with B1 deficiency. So really run-of-the-mill stuff that most of the people come to you to address. So for instance, insomnia, fatigue, muscle pain, body weakness, burning of the muscles, sometimes tingling, neuropathy, but that came much later on. But one of the most consistent findings that they found in almost everyone was that stomach output increased. So stomach acidity decreased. Okay, that was one of the first things. They all developed constipation. They all developed bloating and gas. Basically, I saw this, I was reading this, and I was like, SIBO, hypochloridria. What? This was known back in the 1940s, that one of the first signs of a marginal deficiency or a mild insufficiency wasn't beriberi. It wasn't this end-stage nutritional disease that everyone is looking for. No, it was run-of-the-mill common digestive symptoms: bloating, hypochloridria, acid reflux, etc. And so that was fascinating, because that was one of the first things that they found, and this was almost consistent in every single patient who only had a mild deficiency. It got worse as time went on, and they eventually started vomiting and things in the 3rd month. But what this demonstrated to me was that, okay, people can have let's say they can have a lack of this nutrient. They're not going to develop problems that are severe enough to make them go to the ER. And at the same time, some of the most consistent findings are these people develop really run-of-the-mill digestive symptoms, which most people are taught to treat using probiotics and things like that. Whereas actually, what if we're looking at a situation where we have patients who've sustained themselves on a diet which is based on high-calorie malnutrition? We have people consuming junk food for, long periods of time, and they develop adaptations. They develop adaptations to very low levels of deficiency. But what if we're looking, what if a lot of these, so-called functional digestive conditions are actually a mild manifestation of an underlying thiamine deficiency? So I delved into it more. That's like when I said I started translating a lot of the research in Japanese, in Chinese, and it turns out that from the 1960s, they were treating constipation, they were treating acid reflux, they were treating a lot of these functional digestive issues with thiamine and with thiamine alone. Now, some of the research in China would use a combination of thiamine within an acupoint injection. So they'd actually inject thiamine to the acupoint, and this would be sometimes more beneficial than giving it orally. But in Japan, what they did was they started synthesizing lots of different types of B1. And what they found was that different forms could actually increase the levels of B1 in the body to a much greater extent than ordinary thiamine salts. And this is where you get the forms like benfotiamine or TTFD. They were all developed or synthesized in the 1950s and 60s in Japan. Okay. And so they started studying this. And what they found was that these forms of B1, they could basically use atrazine, which is one of the methods in which they would study constipation, artificially induce constipation in animals, and then they would give different forms of thiamine, and they would find that certain types could completely remove the block that atrazine had on constipation. And it worked by enhancing the release of acetylcholine at the neuron level. And this is something I haven't spoken about, but because thiamine is so central to the production, is necessary for the production and the release of a neurotransmitter called acetylcholine, this is probably how it is working for digestive conditions. So let me just give you a very brief overview, is that what I believe and what I think the research substantiates is that sometimes IBS, SIBO, chronic reflux, basically any function of hypofunction of the digestive system. So if there's a lack of secretion or if there's a lack of motility, and I think most digestive issues fall under that category, most of the people that you would see if you're not gastroenterologist, let's say. But so if there's a lack of secretion or a lack of motility, it is usually because there is a block or there is a reduction in nerve firing from the vagus nerve or from the enteric nervous system to the cells itself. Okay. Now, if we look at what the enteric nervous system uses along with the vagus nerve, what do they use? What neurotransmitter do they use? They use acetylcholine. Okay, acetylcholine. So acetylcholine is known in the brain for improving memory or cognition, and that's one of the reasons why cholinergic drugs are being used quite successfully in Alzheimer's dementia. But if you look at what it does in the rest of the nervous system, well, it's the main neurotransmitter used by the parasympathetic or by the vagus nerve, okay? And the vagus nerve is the thing which is telling the digestive organs what to do. So in someone who, for whatever reason, does not have enough B1, or someone who, for whatever reason, does not have enough of the cholinergic neurons, cholinergic signals being passed through that information highway, then B1 is potentially working by enhancing acetylcholine at the level of the digestive organ itself and at the level of the vagus nerve. And it turns out that some of the early findings on vitamin B1, even if you go into the Japanese literature, there's a gem of a book which was published in 1960. It was translated into English, but it was all of the Japanese literature that had been done up until that point. And what they found was that in many cases, B1 deficiency, not only could it cause, or one of the main presenting symptoms, not only was it low stomach acid, but it could also be high stomach acid. And that was very interesting. And they surmised that it was basically not necessarily just a lack of information or a lack of nervous system signaling from the brain to the gut, but also faulty signaling. So for instance, you may have excessive signals going in one direction and faulty or inhibited signals going in another direction. And this is where it gets to using this clinically. It's where it gets very interesting. But basically what I've learned is that some people can present in opposite ways and both suffer the same problem, the root cause, which is basically a lack of nervous system signaling, but it can go either as excessive function. So for instance, excessive motility or impaired motility, excessive stomach acid output or low stomach acid output. And so it's very interesting, and it seems to come back to nervous system regulation. But even the early research on animals and in humans, they found that one of the first things that tends to go when someone is mildly deficient in B1, not only the digestive function itself, but the vagus nerve. So, and this is where it comes back to this broader umbrella of dysautonomia, which is what Lonsdale specialized in, is that if you lose proper control of the vagus nerve, which is what happens and is one of the first consequences of a lack of B1. If you lose function of the vagus nerve, then not only can you not control your digestive system, but many times you also can't control anything else. So this is where your people who have POTS, who have issues with circulation, their blood vessels don't dilate and open properly, they can't regulate their body temperature, they might get dizzy, they might get orthostatic hypertension, they might have excessive fatigue, or they might feel excessively jittery. So their sympathetic nervous system is in overdrive, or their parasympathetic nervous system is in overdrive, because they're not able to shift effectively between one and the other. And ultimately, if you look at the underlying the driver, many times it is a lack of B1. And I think it stems back to this concept of high calorie malnutrition. Many of your clients, or many of my clients at least, have gone through decades of consuming junk food, and they decide to start on a healthy diet, but that's not necessarily going to resolve, 15, 20 years of abuse to their body. And there are also many other things. If they have some kind of an underlying disease process itself, that may be inhibiting or blocking the utilization of B1. And so we end up with the same principle, that their vagus nerve stops working and that they can no longer make the right digestive their digestive system stops working. And so the symptoms that you might see, and if you look even for something as benign as acid reflux, that can in many cases be one of the first signs of an underlying B1 induced or B1 deficiency induced dysautonomia, simply because every single sphincter is being told what to do. It's being told when to open, when to close. Like I said, there is this coordinated set of events, which is miraculous when you read about it, and you wonder, like, how the hell does this happen in real time? This is like instantaneous stuff. It's crazy. The waves of contraction, the way that the stomach moves is all in like it's like an orchestra of different events, and it's just beautiful and miraculous and amazing that it can even happen. But ultimately, it only happens if there's the right signals coming from the nervous system. And if you lose that, then the sphincter just simply can't close. It's like, yeah, okay, well, we'll open it this time, and then we'll close it this time. Or, yeah, okay, well, we don't know that the food in the stomach is meant to go into the small intestine, so it's just going to sit here. And that's one of the reasons why you have people who have food which literally just sits in the stomach, and they have to do like maneuvers and stuff to get it into the small intestine. It's like, well, rather than just giving hydrochloric acid, which can come in handy, why not, in these people, it may actually be that they're just not getting the right signals. So maybe if we try and enhance the signals, this can help. I hope I hadn't gone too long there. I know there was a lot and I kind of just rambled a bit, but is that the kind of thing you understand this concept, right?
Yeah, I think no, you haven't rambled at all. I mean, everything you've said is gold ultimately, and I think extremely valuable. And I think, one thing almost to stress, even though we wanted to keep this episode sort of quite gut specific, is what you did touch on around the vagus nerve and its role on so many other components of health and function. And if you've got someone in this kind of state with dysregulated vagal tone, that can manifest in all sorts of different ways, even from a sort of decision-making, behavioral sort of perspective as well. So the ramifications are huge and almost endless. So thank you for sharing all of that. It has been super enlightening. I think it's going to be incredibly helpful. I want to summarize the kind of really key practical bits for some of our listeners around. You highlighted how B1, because of its role in the communication highway, the vagus nerve, is having an impact on stomach acid. It's having an impact potentially on pancreatic elastase if someone's done a stool test and they're seeing low levels of kind of pancreatic enzyme function. If someone's got elevated fat in the stool, then we start thinking about the biliary system, and you've commented on how bile production and flow can be somewhat compromised by this as well. So there are, I guess, some key things within a stool test that obviously there are other explanations as to why they might be where they are, but B1 is one of those differentials. It's one of those things we might need to be considering.
Yeah, indeed. And if you are working with patients, you do something like an organic acids test, you might be looking for specific markers. So, as per their interpretation, which you've got to take with a grain of salt, I think, in many cases, but as per their interpretation, if you have certain markers, for instance, elevated lactate, elevated pyruvic acid, elevated alpha ketoglutarate in the urine, then that would indicate a B1 deficiency. And many times people do not have those markers high. And so B1 flags up as green, right? They're told not to look for it. So they assume that it's not a problem. And this is, again, like we were saying, the conventional system assumes that fortification got rid of the problem, whereas the alternative system relies more on testing, which I think is excellent in many cases. But when it comes to thiamine, most of the time, those markers are not going to be elevated. And in someone who's mildly insufficient, the test results show up completely normal. And this is something I'd like to drill down, is that probably most of the people that respond to high doses of B1 or just any dose of B1, most of the time their test results are normal. So that's why I just stopped doing testing at a certain point, especially for people who came to me for B1. And this is what Lonsdale found as well, is that many times the test results will be completely normal. And this also applies to people with the erythrocyte transketolase test, which is considered the gold standard. Ultimately, there's quite little utility unless you're looking for a genuine deficiency. And this stems back to a lot of the research, which I don't really have time to get into, but a lot of the research which can show that there are certain regions of the brain or the heart, just compartments, localized departments, I believe probably throughout or within the vagus nerve as well, which can become like regionally deficient in B1. And this might be because of like what we were talking about, this functional dependence, or it might be a genuine deficiency, which is only occurring in one set of tissues. And so that's not going to affect systemic markers that you're testing. You know, you're looking at urine, you're looking at blood. Well, the overall amount that you have in the body might be good, and that might be not be enough to change or significantly alter the amount that you are, the amount of metabolites that you're urinating out. But ultimately, it can be still localized into the specific compartments. And so, clinically, I would say specifically for the gut, I have found it to be hands down the most effective treatment. Bar anything aside from diet. Of course, there's diets and things that they are your foundational baseline, but it never ceases to amaze me how many people were also not expecting that it would help, and they try it and they're using it for something else. Then maybe they want to improve their fatigue or something, and then they all of a sudden find out that they no longer have SIBO after like 2 weeks, and that's pretty bizarre when that happens. It is something that they discovered in Japan. They've known it since the 60s. They've done lots of studies on this. They've found that it does improve motility and these kinds of things. So it's not a novel concept. It's just unknown in the West, let's say. But in terms of practical value, how you can identify if either you're someone who responds to this, or maybe if your clients will respond to this, is you're going to be looking for someone who is most often tried most of the alternative or even the conventional therapies. So they have tried the antimicrobials. They generally don't respond to that. They are oftentimes dependent on digestive supplements to maintain any semblance of normality. So they're dependent on hydrochloric acid. They're dependent on digestive enzymes. And usually when they stop that, the problem worsens. So, as you know, sometimes just the temporary repletion of these things can be helpful, and someone's digestion tends to normalize after that point. But what you're really looking for is people who that doesn't tend to happen for, and that either they had no response to those supplements, or they tend to be dependent on them just to maintain, like they're dependent on laxatives, they're dependent on these other functional digestive supplements, let's say, to actually just function on a day-to-day basis. So you're looking for people like that. You're looking for people who have had a history of tried lots of the things which are said to work, but oftentimes don't. These people oftentimes have problems with digesting meat because they can't make enough stomach acid or pepsin or whatever it is. They can't make enough of the enzymes to break down and digest the meat. They also oftentimes have problems digesting or metabolizing carbohydrates. So they might find that they have problems with if they consume white rice or they consume sugar or something, it might make them slightly hyperglycemic. It might make them agitated or jittery or something like that. So there can be systemic markers Some of those can also be other symptoms that you would think were unrelated. So for instance, if someone said that sometimes they stand up and they get a high heart rate or they get mild dizziness, that's a key sign. Because why? I mean, as a practitioner, basically think that anything related to the autonomic nervous system, so whether that's sympathetic or parasympathetic, if someone has symptoms within that kind of umbrella, so again, if they have problems with circulation or if they have problems with body temperature regulation, and these things coexist with the digestive complaints, then that should be a warning flag, and you should be saying, okay, well, this isn't just the gut. Like, their issue is clearly not just hypofunction of the gut. There is clearly a problem with regulating the nervous system systemically. So if they have any of the symptoms which could be put down to a systemic dysregulation of the balance between parasympathetic or sympathetic, that should be a red flag. This person may very potentially respond to B1. And honestly, I wouldn't waste your time with testing. This is from just like years and years and years of trying. I've tried every different type of test I've basically got to the point where I felt as though I was wasting money. Now that's not the case. Like, I'm not saying don't test in general. What I mean is don't rely on tests to guide your response. Symptoms are best. And the reason for this is, like I said, thiamine is notoriously difficult to identify, even with the best gold standard testing. So really, if you think you've got someone who would respond, of course, you can rely on testing for things like B6. You can rely on testing for other nutrients, your B12, your folate, all of that kind of stuff. But for thiamine, really, there's just been so many people who get missed. They go to a functional medicine practitioner, and ultimately, they're told that thiamine was never their problem because it didn't show up on a test. And then they waited a year or 2 years until they finally just took the leap, tried it, and then it basically resolved everything. And I've seen that countless times, and it's really tragic. But this is why I really try to emphasize, don't rely on testing for this nutrient. Fact is, thiamine is really safe. It's not even the case with like B12 or folate. If you give too much, then you can kind of screw with methylation a little bit. Or with niacin, you can again deplete methyl donors. There are concerns for liver health. Even with B6, there's concern for toxicity. Ultimately, when it comes to B1, there is no known toxicity. It is remarkably safe. The body will get rid of what it doesn't have. Now, that's not to say that people won't have reactions, and this relates to something called the paradoxical reaction, which is generally the case, and this is something that they also documented in the 1960s, and which Dr. Derek Lonsdale characterized very thoroughly throughout his career, was that generally if someone does have this kind of an issue, what you will tend to see is that their presenting symptoms many times will get worse before they get better. And usually the people who require B1 the most are going to be the people who respond the worst when you start off. And so there's this concept of going very low and very slow as you move forward. I actually have a protocol document that I came up with, basically all the things that I figured out how to try to manage this reaction. It turns out that you can reduce the severity of negative symptoms that someone develops when they start by using other nutrients. Something key kind of clinical note is that thiamine, wherever thiamine goes or whether it's used, it should be used with magnesium. And that's because magnesium participates in the same biochemical reactions is needed to activate thiamine. If you take thiamine, it can induce a magnesium deficiency, like really high doses, especially if someone's subclinically deficient. Same thing on the other way. If you give massive doses of magnesium, you should really be giving thiamine as well. And so there is this interrelationship. So at the very least, using magnesium and B1 together, generally 300 to 400 milligrams usually suffices. At the same time, a general B complex is also advised in that when you're giving a high dose of any one B vitamin, there does seem to be nutritional interactions of just a methylated or non-methyl B complex, whichever kind of works for that person. Those are the general kind of baseline supplements that someone should be taking behind thiamine. And then what I kind of learned the hard way was that chucking someone on a really high dose, and high dose would be, could be anywhere between kind of 100 milligrams to 1,000 or even 4,000 milligrams for some people. The problem with that is that the people who need it, who have all these symptoms, who you get really excited about and you're like, wow, this is going to work, I'm going to try this. Usually they will feel like absolute trash when you start them on it. And it can make them lose faith in you and kind of be somewhat angry and disheartened that you've put them on a supplement which makes them feel terrible and makes them bedbound. So I learned the hard way. It's never a good idea to just chuck someone on a mega dose. You should ideally start very low and very slow. And what I mean by that is it's going to depend on the form. If you use a thiamine salt, then that's going to be thiamine hydrochloride or mononitrate. You could start them on maybe 50 milligrams, but you're going to need much higher doses of those forms because they are generally not very well absorbed. And so you would want to start at maybe 50 milligrams, work up every couple of days to 100, 200, and gradually work up usually past 1000 milligrams. But if we're talking specifically about people who respond with the digestive system, or people have this digestive dysautonomia, then you're going to usually require one of the more bioavailable forms. The best form I personally found is called TTFD. It's not very well known in the West. TTFD has a very special sulfur molecule attached to it, and it essentially just melts through the cell membrane barrier. And so you can get very high levels in the cell in a very short period of time, whereas with other forms, you can't necessarily do that. And so this form is probably the superior form when it comes to addressing digestive problems in terms of increasing acetylcholine, increasing vagus nerve function. But again, you would probably want to start at a much lower dose. You maybe maximum start at 50 milligrams. Oftentimes, I get someone to open a capsule and just take a sprinkle, gradually work up very slowly, and usually the effective dose, average effective dose for this, and I've got a lot of this information on my YouTube channel for free. The active effective dose is usually between 200, 150 to maybe 400 milligrams. Oftentimes you will see that there is an all or nothing effect. Don't have time to talk about this on the podcast, but there's some work on Parkinson's and fibromyalgia, which has shown that basically sometimes up until a certain dose is reached, there's no change whatsoever. It's not as though it's a gradual incremental positive benefit. It's as though sometimes there's no change. It's only when they get to a certain dose, there's an all or nothing effect and their symptoms switch. And you would see, like, basically overnight, say if someone's at 400 milligrams, there's no change, they go to 500 milligrams, and all of a sudden all of these changes start occurring. That's not uncommon. Ultimately, I think the takeaways is that, like you said, B1 is one of probably the most essential B vitamin for managing the information highway from the brain to the gut. It acts directly on the gut, all of the digestive organs, to help them propel things and secrete. A sign of deficiency or even mild insufficiency oftentimes can just present as SIBO, as hyperchlorhydria, even as inflammatory bowel conditions, if there's gut inflammation. And this is because the vagus nerve is not working properly. Like you said, there is also systemic changes. Best way to identify this is really to look at someone who has not necessarily responded, or they've not been fixed by the classical protocols that you would use. Another thing is if they display any other sign of autonomic imbalance, anything relating to dysautonomia, vagus nerve function as a whole, then really it's probably not a problem that's coming from the digestive system. And what you might be surprised to find is that if you get someone on this and you start seeing improvements in stomach acid, you start seeing improvements in gut motility, after you've accounted for this temporary worsening, which can occur for a couple of weeks. But if you start seeing that, don't be surprised if this person starts gaining tolerance to dairy and gluten. Don't be surprised if this person no longer has intestinal permeability, despite you not doing anything to improve intestinal permeability. Don't be surprised if the gut infections start going away, and actually this person didn't really ever have any gut infections. It was just that their immune system was so impaired because they didn't have vagal control of the immune system. Because let's not forget, it's the vagus nerve that tells the spleen to make certain immune cells. It's the vagus nerve which tells the intestine to make secretory IgA, to make the proteins which are essentially involved in maintaining the intestinal barrier, to make the immune defenses against pathogens. So what you'll sometimes see is that when they address B1, is that the gut immune system starts working again. And this is why honestly, man, it's amazing. Like it really is. It's crazy. It's not going to apply to everyone, of course, maybe even not the majority. I think maximum 20, 30%. But I think as a practitioner, if you start applying this, or if your listeners start applying this, they will see those very difficult cases, the ones which no one knows anything to do, and you're just kind of managing them. You have no idea how to address their problem. You try this and you try the different forms that I've spoken about, and you might be very surprised at the clinical efficacy, that you see. And that's why I'm shouting this from the rooftops, honestly.
Yeah, and to be fair, I think the number of people that practitioners are seeing whereby they have chronic digestive issues and they have the dysautonomia symptoms, the number of clients I've spoken to recently who stand up and get lightheaded, some have little dots or sort of start to lose vision. There's a lot, an increasing amount, I think, that would get you thinking that there's something like this going on. So I think it's a really important message to get out there. I have one question for you, Elliot, and then we might wrap up, which is there any data or do you just have any sort of anecdotal evidence? I mean, looking at heart rate variability and seeing improvements going through these protocols?
No, there's a lot of people in my group, actually. So I run a Facebook group. Just to give a bit of background, I don't see clients anymore at the moment. I was for years, and I got to the point where I figured the best way to try to get the message out to as many people as possible was actually to try and, educate other practitioners and things. So I started a Facebook group, and I do content creation and that kind of stuff. There are many testimonials on the group of people who have documented changes in HRV. So that's actually an excellent point. Is one of the ways in which you might also identify a candidate for this therapy is no matter what you're doing, their HRV is very low. It's very low. You're looking in the 30s, 20s, and it's like they can be doing all the right stuff. They're doing exercise, they're doing sleep, but oftentimes they're the ability of the parasympathetic nervous system to go back into a state of where it's meant to be, it's impaired in these people. So HRV is a good measurement. I think there is research. Well, there is research looking at how a mild dysfunction of B1 or cholinergic function in the vagus nerve is also one of the things that is going to impair HRV. Like I said, there's a lot of people with IBS type symptoms, which have demonstrated in the studies to have low heart rate variability. And I've worked with several people who they tried everything. They tried lots of the different supplements and things, but it was B1 that's a missing link. But again, I don't want to give off the impression that this is a fix-all, because it's not. It's definitely not a panacea, and it's not going to work for everyone. Although what I would say is that there's clinical evidence or experimental evidence, and there's also a lot of anecdotal evidence. You go on my group, do some search functions, and you see lots of the testimonials. Also, the product that I sell, Thimax, some of the testimonials on there, or on my YouTube channel. Just go on my YouTube, go on the video about the gut. I've got a couple of videos on the gut, thiamine on the gut, and just look through the comments. I mean, dude, there's like thousands of people who've said, I tried this and this improved it. So it's like, this thing does work. But there is some evidence that you don't necessarily even need to be deficient, in that it's having a pleiotropic effect, or let's say a nootropic effect, in that, let's say you do have enough B1, but giving a little bit higher amounts of B1 can increase the amount of acetylcholine that's released. And so it's therefore going to increase parasympathetic responsiveness, let's say, or vagal tone, improving vagal tone, even if someone doesn't even have an insufficiency from a nutritional standpoint. It's more having just a nootropic action on the neurons themselves, and giving a little bit extra, a bit like a drug. You give a little bit extra and it just increases the output, that slight amount. So yeah, HRV, that's something which can be used and it can be tracked, and you will see pretty substantial improvements in someone who is going to respond within the space of about 3 or 4 weeks. And you can see on the graph, like when they take B1 and then when their HRV starts going up, it's not necessarily going to go up past 100 or anything. I mean, that would be crazy. These people have to like start retraining their entire cardiovascular nervous system. But ultimately, you can see a bump up of like 30 points, which is excellent for these people, because they've been sitting at like 20 or 30, sometimes even like 15 for years, and they don't know why. So yeah, that is something that's useful.
Amazing. Okay. Elliot, thank you so much. This has been it's been really interesting. I think a lot of people are going to be curious to learn more and to check out your content. I'll put links into the show notes for everything. So I think there's your kind of your own website. I think there's thiamineprotocol.com.
Yeah,
And
yeah.
obviously your YouTube channel where there's loads of free content, as you say. Um, so people can probably reach out to you via those avenues as well. Is there anything you just want to sort of conclude with, Elliot, or do you think we've covered it all for today?
I mean, I think we've covered a lot of it, right? If you're a practitioner, like I said, and this is kind of having to beat it out of yourself, you get a client to pay several £100s on a functional test, and it doesn't show the vitamin that you're looking for. That's not a reason not to try it. It's a completely safe and effective method. There's some people who don't respond, and like I speak about, I've got several hours of lectures. I've just published, like this month or last month, I just published like 4 or 5 hours of lectures specifically geared up to how to use this clinically. So I go through all of the different forms. I go through everything like that. I can give you links to that to put in the show notes. So the information in terms of how to practically apply this is available. It's all available online for free, which I've put out there. What I would say is never rule someone out, even if their tests come back normal, because you might be amazed at how many people do respond to this. Understand that someone may have an imbalance or a nutritional deficiency even when they're eating enough through the diet. So just doing dietary analysis, I know some practitioners do it. I don't personally do it. But let's say if you have your clients running things through Nutritics and things, and you see that their thiamine is good, never use that as evidence that you should not consider this nutrient. Use your brain, use your understanding of anatomy and physiology, and listen to your patient. If your patient is telling you something, if they're describing a classic set of symptoms or a certain set of things which highlight an imbalance in a system of the body, try and remember that thiamine can be one of those things that can address those autonomic imbalances. And as I said, I mean, all of this happened by chance. The fact that I specialized in this, I wasn't expecting to see the benefits I saw. You know, you read about it in a book. Most of the therapies that I've used in people, like I read about studies, I read about in books about how they're so effective, but half the time, like people don't even respond that well. You know, it's fairly underwhelming, like certain gut protocols and things like that. And I know that many of them work, and there's lots of things that can be really effective, but there's also a lot of things which people big up and they're like, yeah, this is amazing. Look at this evidence, blah, blah, blah. But in real life, it doesn't actually translate for whatever reason, or it's let's say it's underwhelming. Well, thiamine is the opposite of that. And I want your listeners to kind of trust me on this until they live it, you know, until they actually try it and they see, is that this is something that no one is bigging up other than basically myself and a couple of other people. You won't read that many studies about how this is amazing for the gut, how this is this, how this is that, unless you want to learn how to speak Chinese or Japanese. Ultimately, this is something that you're not being told is excellent, but that has so much clinical utility. It's basically untapped potential, which I mean, it's just a miracle that not more people know about this. So that's what I'm trying to do, get the message out. So I just say, for your listeners, have faith, try it, work up to a specific dose, follow my other recommendations. I've got a bunch for free online. Check it out, and give it a good go. It might not be the panacea, but it might also work. So if there's a chance, because it's pretty safe and effective therapy, it's worth trying. I'll be in London in November. I'll be giving a talk on this concept, on megadose thiamine and the principles behind it and the conditions it can be used for at the ICANN conference this year. So that's one thing. If any of your listeners are going to be there, make sure to check that out. That won't be focused on the gut. That will be more focused on the broader concept of using megadoses and the mechanism behind that. But no, there's an animal here that is ready to be unleashed. The concept of megadose thiamine, really, it's going to come out at some point. It's got to, it's got to. So we'll just wait and see.
Yeah, well, you're waving the flag, and I think doing a great job in raising that awareness. So, Elliot, once again, thank you for coming onto the podcast. I think this is going to be a really popular and helpful episode. So, thanks once again.
You're more than welcome. It was a pleasure. Thanks for having me on, man.